before we start, I would just like to recognize that if we were all at McMaster, the traditional PFD event, we would be on the territory of the Haudenosaunee and Anishinaabe nations. And this territory is covered by the Upper Canada Treaties within the lands protected by the Dish with One Spoon Wampum Agreement. And we're directly adjacent to the Haldimand Treaty territory. And I would also like to acknowledge the other First Nation territories that many of you are on at the moment. So the topic today is teaching and supervising junior learners in virtual patient care settings. I'm your facilitator. Dr. Teresa Chan is the, I don't know your title, Teresa, I'm sorry, head of PFD. Thank you. And, you know, organizer extraordinaire. Teresa's just so adept at helping to break this all down for those of us that sometimes feel a little intimidated by it and making it all happen. So thank you, Teresa. The objectives today are to give you some information that you can incorporate into having best practices in virtual care supervision in your own environments. And I recognize many of your names because you're actively involved with our UG and PG learners for a long time. And I'm sure that this pivot into teaching virtually is daunting. I'm grateful as an intensivist that I don't have to do virtual care. Yeah, imagine that in the ICU. But I have had to have a lot of virtual family conversations and difficult virtual family conversations. And so I have paid keen attention to some of these practices because even though I don't need them directly with my patients, I need them with my patients' families. So learn about considerations for counseling clients and their families via virtual care. So no matter what we do in medicine, that likely has come up and will come up. Also to highlight important considerations in communication with particularly junior learners and patients related to virtual care encounters. So how do you prepare your patient to deal with a junior learner in virtual care? How do you prepare yourself, and how do you communicate with both of them? So our speakers today, I believe in order, is that correct, Teresa?
Yes, I believe so.
Okay, first we have Dr. Keena Bracken from Family Medicine. Then we have Becky MacArthur from Speech and Language Pathology, Dr. David Fahmy from Allergy and Immunology, Dr. Heather Waters in Family Medicine, and Dr. Maria Taboni in Internal Medicine. And each of the speakers will also give you a little bit of the background and why they're here today. And please don't forget to consult the website, which also gives you a more comprehensive bio of each of our speakers. And I really, again, want to thank them for the time and effort they've put into this because sometimes it's hard to get folks to think about, you know, the spectrum of learners across the Faculty of Health Sciences. And many of us in our practices actually encounter nursing learners, physio learners. The other day I was working with a spiritual care intern. So, you know, I think we need to be comprehensive when we think about the needs of learners and think not just about the spectrum of learners from the Faculty of Health Sciences that we encounter, but also the spectrum of learners right from a very early clinical clerk all the way to a very senior resident. And today we're talking about those clinical clerks and junior residents in this talk and people that are at the equivalent level. So yeah. I will stop there and hand it on over.
Excellent. So one amendment I was going to make is that we will actually be inviting Becky and Heather to co-present together. So they're going to go right before David there. And we're going to put Kenya now on the spotlight, and she can share her slides as needed.
Thanks, everybody. So I'm Keena Bracken, and I am the undergrad director and clerkship director for family medicine. And I also am the, and I always forget the name of this, clerkship longitudinal experiences. I think that's right, or something like that anyway, Jill. So at the end of the day, this is a topic that became very important for me to quickly gain a little traction on, and trying to figure out the best way of approaching family medicine clerkship in a new world, and the new world that we've all been rather dramatically thrust into. So it became a question of how do we actually manage this, because most of family medicine clerkship, if not most of what we try and do, is achieved in a preceptor's office when you're actually working with students. And typically that's involved an enormous amount of inpatient direct patient care, or in-person direct patient care. So this was a huge change. So here we are talking about virtual supervision, virtual care, and what are we actually talking about? So definitions are usually in order. So this one, it's really a broad term, something that encompasses all the way that healthcare providers can possibly interact with their patients remotely. So that could be a variety of different modalities, including live video, audio, instant messaging, and sometimes the definitions become a little bit more challenging when you think about, is there a difference between virtual care? Is there a difference between telemedicine? Is there a difference between telehealth? And I'm going to put it to you that it really doesn't matter so much. The semantics perhaps are a little bit different, and that telemedicine really talks about also the delivery of technologies. And you're probably aware that there are some remote technologies that through various health-related apps, people have started to communicate remotely with their patients. This could include, for instance, oximetry. It could include various other cardiac modalities, blood pressure monitoring, sometimes direct blood sugar capabilities back and forth to preceptors and clinicians. So really, it's the whole spectrum of what we're talking about. And we have to start to think about what parts of virtual care can we deliver the best, what parts of virtual care may be a little bit more challenging, and not to forget that there are particular nuances of virtual care that we need to be aware of when we don't have that patient in front of us to potentially give us cues that may make reading them and reading their situation a little bit easier. So I think it's fair to say that all of us know exactly what or have heard the term virtual care many times since March 13th, which is the day I came back from Hawaii and went into quarantine. So it's rather indelibly imprinted on my mind, and some of you may have other dates, but all around that particular time in March. So this article you may have seen in CBC May 18th, 2020, which really was talking about how COVID has pushed healthcare in the virtual world. I think all of us can agree that that is definitely the case. We're going to talk a little bit more about how this technology existed prior to COVID-19, but certainly since this has happened to us and happened to everybody that we know in our entire world, really, we have gone light years forward in something that probably would have taken many years to get to the stage that we are at now. Interestingly, back in early January, the Canadian Medical Association had a meeting, and they were talking about starting a task force because they recognized that virtual care had the potential to increase access not just to primary health care, but also to specialist care for Canadians. And we've been doing this for a variety of different countries and a variety of different places in rural and remote communities for some time. So while we had the technology and the ability to deliver that type of virtual care, there were a lot of barriers to its widespread adoption. And many of them will be familiar to most of you, including payment models, licensure and quality standards. And I've highlighted that last piece, which is education and training, because like most of us, we've been thrust into an environment that we didn't know very much about and had very minimal training, if any, on how to actually deliver this type of care. So it's a work in progress and something that we all have to be mindful about as well as we move forward. So my point here is that this was on the table in January of 2020 before any of us realized how much our worlds perhaps would change with the results of the pandemic. I mentioned before, there's certainly been experiential practice with virtual care prior to COVID in the United States, particularly in Scotland, as well as rural and remote areas of Australia, the UK. As mentioned, the US, particularly Minnesota, and the University of Minnesota has done quite a bit in this regard in the past, and certainly in their more remote regions of Canada. We've been accustomed to having telemedicine, as we used to call it, a little bit more there, where you have patients in a remote setting that don't have access to especially to a specialist, and then their care is provided via remote access. So we know that it was certainly possible to do it. We didn't have a lot of experience in terms of monitoring or supervising junior learners, however. In Australia, they had been doing a little bit of this with more like their junior house officers. So these would be sort of the equivalent of what we used to have as interns or perhaps R1s who are working in more rural settings and don't have a preceptor that's actually with them. So they would often record their video encounters with patients and send it back to the preceptor for feedback that way. So there is some precedent prior to COVID that this in fact was doable, although not a lot of experience in doing it in terms of the more junior learners, as I've mentioned. And I had never heard of this, but medical virtualism was a thing. So it was a thing even pre-COVID. So I've just highlighted 4 articles that I managed to find in my sort of review of what we knew about virtual healthcare prior to COVID and what's happened afterwards. So you can see that these articles were published as early as 2015 and then up to about 2018, 2019. So these articles have a gamut of things. So some of them talk more specifically about the technologies that you can deliver remotely to patients. Some of them talk a little bit more about the like that last one, incorporating a new technology while doing no harm. So some of the more difficult nuances about interacting with patients over technology and how you may lose some of that ability and perhaps some of the empathy that we strive very hard and is an integral part of what we do as healthcare providers. So a number of articles were around to talk about how we actually could do this better way before we ever knew that something like COVID-19 would hit us. And then, as we all are probably aware from reading various medical education journals, if nothing else, a variety of organizations were very quick off the mark, and we've seen many journals exclusively donated or devoted rather to publications related to how schools in general have managed the pandemic response and what they've had to do to change their medical education delivery systems. So a couple that I highlighted that were quick off the mark. The first is a British group, which was remote assessment in primary care. So this was a GP practice setting and published in the British Medical Journal early in, I think it was actually in April in 2020. And their experience led to a slide that I will show you in a little while, but certainly very quickly describing how even junior learners could actually see patients and have supervisors that weren't necessarily in the same place. The University of California at San Francisco, mainly through Kaiser Permanente, is the second group, and that link there takes you to a huge resource area full of what they managed to accomplish with a group of longitudinal clerkship students. The University of California at San Francisco and Kaiser, if you haven't been there before, and I had the privilege of doing this a few years ago on sabbatical, have a number of different longitudinal integrated clerkships set up. So they're accustomed to seeing a panel of patients. So even while the universities pulled students out of hospital settings, these particular students continue to see their panel patients remotely with their preceptors also remotely. So I really used a lot of material from them and attended a couple of webinars that they put out very early on in the pandemic to give me some more ideas as to what we could potentially do in Hamilton. And the last one, humanism and telemedicine, I think I wanted to highlight because this really talks about what the quiet sort of empathy and the skill set that you need to communicate with effectively, and the communication skills are really highlighted in a remote virtual-based setting. So this is the publication that came from the British resource that I just mentioned. So why are we even bothering to think about virtual care in this context? Is it good for everything? When should we be choosing it? Why should we be doing it? Some of those are obvious, I think, as in it can help with managing isolation or social distancing, which was why isolation was always an issue for some countries and some provinces and other remote settings in the world. The decision to choose it is shared between you and the patient. I think that's important because there certainly are patients that are not keen on doing this type of interaction. They may not have the technology, they may not have the Wi-Fi access or a secure Wi-Fi source. They may not feel comfortable with the technology. All of these things need to be taken into consideration. I think the other piece that we think about often but don't necessarily state is what the nature of the encounter is. So we hear all the time emergent visits are not appropriate for virtual based care, and we want to make sure that we're not missing diagnoses that require an inpatient person assessment. The calls are safe and secure, the PIPA modality, and we get into that, the Personal Health Information Protection Act. That's something that we obviously need to be very compliant with. So we'll talk a little bit more about that later, and I'll point you to a resource if you're interested in the e-module that I developed earlier. But I'll tell you about that in a second as well. But it is important to make sure that you're communicating under a safe and secure modality. And then I think this point, it saves patients stress, time, and travel expenses. That's something that moving forward, many patients enjoy, the fact that they don't have to pay for parking. They aren't worried about physically removing themselves from their homes in times when it may be very stressful and actually not a great idea for them to do so for a variety of reasons. So the e-module I developed back in the end of May was really trying to pull together what I managed to source from my quick scoping literature review. And within Mac Health, there's a number of various excellent resources that many people have provided. This was the resource list as part of the e-module that I developed, Supervising Learners and Virtual Care. So it really does talk about both undergraduate as well as postgraduate learners, but it might be something that you want to look at on your own time if you haven't already, which gives you a much more specific breakdown of all of the essential components to providing good virtual care. And then there's another one, which I'm going to, hopefully isn't going to start playing. This was heavily borrowed from the Kaiser Permanente University of California, San Francisco series that I told you I participated in over internet. So this is really the synopsis of what they try and do. So if you look at the e-module later that I developed, you'll see that it really does lay the groundwork, which is number one, which is circled, which is the preparation piece, both from the student perspective as well as the patient perspective that's critical to a successful encounter. Then two is the actual sitting by the fire, which is the student-patient encounter. And then the third is the synopsis with the coming together of the student, the patient, and the preceptor all together. So I won't go into any more details. You can look at the module if you're interested in that, but it really does talk about the importance of engaging everybody in that triad. So preceptor, patient, and student, setting expectations early, and then making sure that you have a debrief time to go over things, both from the preceptor student perspective as well as the patient student preceptor triad. So I think I'm going to end there. Thank you.
So we'll move on to our next presenters, who I believe are Becky McArthur from Speech and Language Pathology and Dr. Heather Waters from Family Medicine.
Hi, everyone. My name is Heather Waters. I'm a family doctor here in Hamilton. I work at the Stone Church Family Health Center, which is one of our family medicine teaching sites, where we very regularly have both postgraduate and undergraduate learners, as well as interprofessional healthcare learners. My co-presenter and I will be talking about teaching history taking and counseling skills to junior learners. And Becky, I'll let you introduce yourself before we get started.
Wonderful. Hi, I'm Becky McArthur. I'm a speech and language pathologist in private practice and the owner of We Communicate. And I'm really excited to talk about counseling skills tonight. I will preface this with Heather was very nice to note that I typically use the word client in private practice and in speech language pathology, so client and patient are interchangeable tonight. This is sort of a visual schematic of what we're going to be reviewing tonight, and something that you can use as a visual for yourself as you are supervising junior learners, as different ways that you can move through. It's not necessarily a linear thing, like one time for each part of a placement, but more something that will be cyclical, that you'll move through multiple times, even within one student placement. So first, we're going to chat about knowing your learners. So it's really easy when you have a placement, a student on placement, and wanting to hop right into teaching opportunities and growing their skills. But this step is really important to be intentional about setting aside non-patient time in order to connect with your learner. This can be more difficult in virtual patient care. So this past summer in COVID, I had a student on placement. And to give you a little bit of background, I'm providing only virtual patient care right now in private practice. And so I was at my home in Waterloo, my student was at her home in Hamilton, and all of our clients were at their homes within Norfolk County. And so it was really important for my student and I to set aside and schedule time to meet outside of patient direct care. And so two things to consider are how you're going to do this and when you're going to do it. So you could do this by phone, video, or even e-messaging communications, and you could do it before, between, and after patient visits, but it's important to schedule it into your schedules. These times of connecting with your student can be really great for learning about their experiences and their skills. It's also a way of observing their people skills in a less formal setting, and we'll chat more about these people skills later on and how they're important for counseling. And then also to identify their learning goals and what they hope to set out to learn in their placement with you. The next thing to consider is setting up for success. So first and foremost, you as a supervisor need to know the technology that you're using and the platform that you're using and be pretty comfortable with it. And then ensure that you set up ample orientation and training for your learner on that same technology and platforms. And so this could be by yourself as a supervisor, another staff member, or even IT if you have access to that. But ensuring that you set aside time to do this, again, being intentional about your time, so that you can do this right at the beginning so that you're not kind of fumbling with it as you move through the placement. In addition, you want to utilize observation and shadowing early on in a placement, especially with junior learners. They may be observing and seeing things for the first time in a placement with you, and then slowly moving towards gaining independence. And as a student moves toward more independent opportunities, you want to be selective about their direct patient care opportunities. So an example of this might be working with a family, having an opportunity for a counseling moment with a family that is in general less emotional. We've all had clients who are in a season of their life or in a season of their path with you where they're very emotional, and that may not be the best first opportunity for one of these junior learners. You can also identify a specific task or goal. So rather than just setting them out in an entire session, giving them a specific task to do. So an example could be reviewing the specific treatment options with a client, and then having you as a supervisor there to sort of go through Q&A and more of the discussion. Lastly, you might consider scripts and templates, and this is something we do in speech-language pathology as junior learners. I think in speech-language pathology, sometimes the junior versus senior learners is less of a dichotomy because we only have 2 years of schooling. And so for almost every placement we encounter, the information is completely new. We have never seen it before. And so we use scripts in order to ensure that when you're connecting with a client in a direct patient care opportunity, that you've had an opportunity to think about, rather than using all of the jargon that we use, how you explain these things to our clients in more layman's terms. So an example might be in speech pathology, since we have lots of medical folks here, rather than having a student jump in and start explaining, we may use phonological intervention or maybe a motor speech disorder approach. Those are terms that our clients are not going to understand. So how do we better explain it so that our clients feel, clear with the information and empowered and not confused? So that's another thing that your learner can use. In addition, so now we've talked about knowing your learner, setting them up for success. Now we have them in some opportunities to have direct patient care, and how are we going to scaffold and support them? So something to think about is that support with a junior learner is not always linear. It's not always we support them the absolute most and then take that away. Again, it's really going to depend on the situation, the client's reactions, the information that they're providing, so many things. So it's important to remember that you may take this on and off throughout a placement. In my placement with my student this past summer in COVID, it was fully virtual. And so we would use verbal and nonverbal cues to move between these support levels. So for example, if she was in a situation where her video was on and she was doing direct patient care with a client and my video was off, she may use a verbal cue like, let's have Becky come back on and speak to that, as a verbal cue to let me know she's needing some more support. Or she may use a nonverbal cue like requesting my video to turn back on in the back end without a client hearing that. And again, some options are to have a supervisor's video on or off to increase or decrease support. The learner's video could also be on or off in a virtual patient care situation. So an example of their video being off would be a very passive observation early on in their placement. You can also vary the amount of content that they have to review and the amount of time that they're spending with a patient. And it's really important to know, Heather can speak to this maybe a little bit more specifically, but making sure that a learner knows that if they are in a situation where the supervisor is not present and they are directly connecting with a patient and they are unsure of something they need to ask or review with you, that they can do that and then come back to the virtual patient care interaction.
Thanks, Becky. Although Becky and I have a fair bit of experience and a lot of ideas about supporting our junior learners in the provision of virtual care, we thought we would take a moment to actually ask one of our clinical clerks who's just recently doing a medical rotation up at Stone Church Family Health Center about one of the biggest challenges that she has faced completing clinical clerkship rotations in a virtual care environment. So with advance thanks to Maya Amar, let's hear what Maya had to say.
Maya, what have you found most challenging as an undergraduate medical learner at the clerkship level, providing virtual care to patients?
So something that I've found difficult, sort of adapting to this process of virtual care, is that I think you can often get a good history over the phone, and you can get like a thorough story, but I think something that's difficult is that you lose the ability to pick up on some nonverbal cues and to really like develop your skills in like observing patients and just sort of the observation part of the physical exam, which I think can make it difficult to make a very accurate assessment sometimes.
We'll talk a little bit more about that shortly. And I know that our next speaker after Becky and I is going to talk a little bit about physical examination in the era of virtual care. But thinking a little bit more about what Maya talked about related to losing some of the visual cues, we do want to acknowledge that those can be quite important as basic communication skills, particularly related to history taking and counseling. At Stone Church Family Health Center, and probably in a lot of the areas that you work, you may employ layered learning strategies using more senior learners, senior residents to help supervise some of your junior learners and medical students. And building on some of the themes that Maya brought up for us to consider, you'll be interested to hear what Dr. Saj Tavasoli had to say about some of the challenges of, as a learner himself at the residency level, some of the challenges he's experienced in layered learning models where he is helping to supervise and teach more junior learners. And this again is in the family practice setting. So we'll hear what Saj has to say.
Okay, so I think the one challenge that I've been able to identify is the fact that having virtual care, you almost feel like you are one step farther from that patient interaction. So you don't have the patient in the clinic with you to assess them. And if you're sending a learner to speak with them over the phone and then kind of relying on that information, it almost feels like there's this one extra filter between you and the patient. The one thing that I found helpful in helping me kind of resolve that issue is spending some time just getting a general sense as to how the patient is, so deciding whether they're sick or not sick, and using some general questions about how they've been, say, this week or the last week, and allowing myself to kind of visualize that patient in front of me to get a sense as to what I need to do and how I need to plan their management.
And I think Saj's comment relates back, Keena, to a comment that you had made about helping to prepare the patient for the involvement of a learner. So I know Becky and I have really focused on making sure you and your technology are set up before you help to get the learner set up. But I think Saj is reminding us of the important point that Keena highlighted about also preparing your patient and setting the stage yourself, just to ensure that this is a safe and appropriate encounter for a more junior learner to get started with. In terms of history taking in the era of virtual care, I think it's really important that we give our learners permission to hear your patient's story. I think there can be a tendency for all of us, and more junior learners in particular, to become distracted by the medical record, by the particular modality that you're using for the virtual visit, particularly because our learners tend to transition on a very regular basis from rotation to rotation, being required to, to very quickly and flexibly adapt to a variety of methods for record keeping and connecting with patients, sometimes that can be quite distracting. I think learners can sometimes become overly focused on their own performance, on their own recording of information, on where to find and access information in a chart. And what I always like to do when I'm starting off with junior learners is just to remind them that the focus should actually be on our patients, that the patient is the key person in that moment. And the most important thing is that they focus on getting to know the patient a little bit and building rapport and trust, because that in and of itself is actually going to help elicit so much of the important information that's required for the consultation. It's always important, you know, to remind our junior learners to allow the patient to explain their story and what's brought them to this appointment, and give them the opportunity to speak before interrupting. And certainly, as they would have done in person, you know, just an important reminder that even though we're virtual, that it's okay to ask patients to clarify things when they're making comments that are vague, using terms that could be understood in a variety of different ways, that it is important to stop and either ask them to elaborate or clarify or give examples. Maya told us about some of the challenges that she has faced in terms of the loss of verbal, or sorry, the loss of nonverbal cues, particularly with phone-based appointments. And we can still pick up on a certain number of nonverbal cues in video-based appointments. And again, just reminding our learners that more than ever, when the patient isn't physically with you in the room, it's really important to listen for verbal cues and to watch for nonverbal cues. And again, if there's any uncertainty, not to hesitate to ask. As Becky alluded to already, you know, our junior learners are developing knowledge and skill, and efficiency is generally not a strong suit, nor is it the area that we really want them to focus their attention initially. I mean, quality of care and information gleaned during history taking is, you know, needs to come first, and efficiency is developed over time. This being said, we all have busy clinics to run and multiple responsibilities we're juggling every day. So we often find it helpful in our teaching unit to provide a time limit for our learners. And even if that means, as Becky suggested, that they only do a portion of an assessment or they focus on a specific aspect of the visit with the patient, I think providing them a time limit does help them to gauge the focus of their interaction with the patient. Dr. Ellen Clark is a family medicine preceptor up at Stonechurch Family Health Center who does a lot of medical teaching with clinical clerks and with medical residents. She's very accustomed to the layered learning model. And I had a chance to ask Ellen what she noticed is the biggest difference between supervising postgraduate medical learners from more junior learners. And here's what Ellen had to say.
Dr. Clark, thanks for taking time to join me today. What do you find the biggest differences between supervising virtually between postgraduate learners and medical students?
Well, one of the things that you really have to spend a lot of time focusing on them. So you need more time. You can't be distracted by other things. You really need to spend the time monitoring them and listening to them so you can really give some good educational feedback.
Thank you, Dr. Clark.
So just to summarize there, Becky and I do really want to highlight for all of you the importance of direct observation. And this requires specifically staking out time to watch the learner interacting with the patient, taking their history and communicating. You can glean much richer and different information than that gleaned from a case presentation. So although it might not be possible to observe every moment of every encounter, again, in the context of our very busy clinics, I am going to ask and encourage you, if you want to set up a successful learning environment for your junior learner, to make sure you do take some time to set aside multitasking and really focus on watching and listening to them, as well as making time to provide feedback, to review scenarios and teach with them. And I think I've already spoken enough about using layered learning models and team-based approaches to support optimal teaching strategies. So in final words, we just asked Maya if she could highlight for us something that as a junior learner in medical in medical rotations, what she has found most helpful to support her in learning virtual patient care.
Maya, what have you found most helpful in learning virtual care of patients?
Something that I found extremely helpful that I've been privileged to have in this clinic is that while I'm taking a history from a patient over the phone, I can have either my preceptor or the resident that I'm working with listen in on the history and then give me very directed feedback about the way I inquire about certain things or the type of questions that I ask, as opposed to giving me sort of general feedback after I've relayed the history or after they've read the note that I've written. I've never really had the opportunity to have such sort of directed, specific feedback, and it's been very, very valuable for me. And it's not an experience I've been able to have before, and I know it's something that a lot of my classmates that are doing a similar sort of experience with virtual care don't have the opportunity for either. So I think that's been great and very, very valuable.
We're happy to address any questions related to direct observation in the area of virtual care in the Q&A session at the end, but I'm going to keep things moving and hand it back over to you, Becky.
Thanks, Heather. So to kind of begin the wrap up, to kind of jump off of Heather's point there, chatting about patient history taking, thinking about counseling as a relationship that requires caring and connecting, as well as maintaining objectivity. So this will involve listening, similar to the task that Heather was just speaking to, but also educating and guiding. And I'm going to speak a little bit to that now and how that educating and guiding can be really difficult, especially in virtual patient care. So counseling in general relies a lot on soft skills, and as contrasted with hard skills, which we think a lot more as teachable skills or skill sets. Soft skills are the way you relate to and interact with other people. So we sometimes call them people skills. And so sometimes these are more difficult to really give objective feedback on, but also not always given the due priority in education and patient care. I do want to share a little success story, though, that counseling can be really successful, the teaching of counseling over virtual patient care. My student from this summer, she was fully virtual, and I hired her. So our learners can grow. They can really blossom in a lot of these areas, both their technical hard skills, but also these soft skills with the right direction from us. Counseling can also be challenging because of client and family factors. And when we think about the world right now, many of our client and families are struggling in not only the reason why they're coming to us, but in many other ways. And so it's important to keep that in the back of our minds as service providers, but also making sure that our learners are aware of that too. Changes with virtual patient care, it can be very difficult to set up the learning environment. We've talked about this. You may physically or geographically be in different places. Scheduling everything in our days can be a lot. Something that I've noticed with especially counseling in virtual patient care with that learning environment is that when you're providing really difficult information to a family, sometimes physically when you're with a client, that silence can be a lot more bearable. But the electronic silence, when you've provided really difficult information, can be very awkward. And again, as medical professionals, you may not be doing that quite as often. As allied health professionals, many of our colleges have recommended the continuance of virtual patient care exclusively unless we cannot provide the same level of care, not virtually. And so many of my counseling opportunities, all of them since COVID started, have been virtual. So that's something that can be more difficult and something to prepare your junior learner for if they're going to have situations where that may come up. It can also be very unpredictable. Counseling is one area where it's very bi-directional. We're getting lots of information and picking up on client cues, and that will change the situation. So counseling can be a challenge. But lastly, a way of setting up for success is providing really good feedback and reflection opportunities. And Heather has touched on this a little bit already, but really important to use reflection for growth for a learner, especially starting from day one when they're observing only. So making sure that they're reflecting on what they're viewing and visualizing with a patient and how they will use that to grow those soft skills, those people skills. In addition, we want to make feedback as objective, clear, and specific and timely as possible. As Maya mentioned in her video, that direct feedback that was really specific, contingent on timing right after, really helped her learning. And you could use rating scales like the clarity of a message, and also connect with your clients to see how clear the information that they were given from a learner, how easily it was received. And last but not least, being honest with our learners, that the honest truth is that counseling skills take time. And for many people, lots of learning opportunities to foster. And that's why we want to use specific feedback and reflection at every opportunity in order to grow these skills. And just to go back to this infographic that you're more than welcome to use to sort of imagine how you can continue to support a learner to help them succeed. Thank you so much.
Now we're going to move into physical exam with Maria Taboni, one of my colleagues in internal medicine. I'll let her further introduce herself.
Thank you very much, Jill. Well, I'm an internist, a colleague of Jill, as she said, and even before COVID, I really got on board with telehealth and virtual medicine. And I was fortunate enough before COVID, hit us to do 2 courses virtual at the Jefferson University. And now I'm officially a telehealth facilitator, which is that individual that is the interface between IT and your patients. And fortunately, when we saw the worst of COVID, and I'm very involved with the bariatric clinic at St. Joe's, we were very able to switch most of our encounters to virtual. And we were basically the only clinic in Ontario that was able to keep up with absolutely everything. So I'm gonna share my screen. Give me just 1 second here. Perfect. And I think that it's some of the things that I'm gonna be mentioning at the beginning, we already heard. And so I think we are very aware now of what are the pros of doing virtual encounters and virtual physical exams. Very convenient for the patients in terms of times and cost saves, and making care for them definitely more accessible. And I do believe very strongly that also is very convenient for physicians. You have now the opportunity to have an encounter and do a physical exam, not in your office, but seeing into the world of the patient at home if they are at home. Definitely, we all know, well, the science is telling us that increases patient satisfaction, and also for the physicians there are other advantages of virtual care, less office stay and wear, and we are seeing at the clinic, and that's what everybody is finding, that there's actually much less no-shows. When we have to teach our learners, junior or more senior learners, of these virtual encounters and the physical exam, first we have to understand ourselves what are the limitations, and there's very limited data on the validity of a virtual physical exam, and we know that there's a tremendous amount of limitations that we could encounter as we do our encounters and physical exams. From technical, the signal is not good, you lose the patient where the patient is on Zoom. The physical exams, virtual physical exams, they have the potential for being incomplete, in the sense that we cannot do auscultation, we cannot do palpation. And if you have a particular situation where you in your office, for example, you will do a special maneuver, well, sometimes, very challenging, you won't be able to do that when you see a patient through a camera. I think that it's very important to know that the physical exam, the virtual physical exam, is actually new for all of us. So we don't have JAMA rational clinical virtual exams to tell us what we can do and has been validated, but it's the experience of all of us that have been doing quite a few assessments that what is actually bringing these virtual physical exams forward. It's important to understand that this is a new field, and patients and physicians, we are not all of us are very savvy on what can be done or not be done. So when we teach our learners, we have to make sure that we understand the limitations ourselves first. I'm not going to go over these two next slides in detail, but I always tell the learners when they join me for a preoperative virtual exam that they have to keep in mind that these encounters, although they are virtual, they should be and remain very professional. So we should be dressing properly, using very proper professional language. And especially when we're engaging with the patient, I think that the website manners are different from your usual bedside or when you are in the office. And we as physicians, in order to teach our learners, we have to understand those very well. It's important when the residents join me on virtual physical exams, it's interesting when you have the two Zoom cameras to see the things that you wouldn't like to see if you were the patient. For example, when you are engaging with a patient, it's important to look straight at the camera, not at the bottom of the screen, because the patients can pick that up very quickly. It's important to let our patients know what we're doing. If we are typing, for example, I usually tell them, listen, I'm going to be typing. You might hear me hitting the keys of the board. If I'm reviewing at the same time that I'm seeing the patient the test, we need to let them know. You're going to see my eyesight wandering. I'm just going over different charts, different aspects of your chart. And I think that the most important thing also is that we have to become really very aware now that our body language, our expressions, they really get accentuated on the camera. If you guys can see me now, if I'm looking at the camera now, as I am, I'm looking straight into your eyes, I'm engaging with you. If someone were to come into this room now and I roll my eyes, I look to the side, if I get distracted, it really shows in the camera. So it's very important for us that we recognize that the body language is actually very important. I'm not going to mention what we have discussed in prior courses about the office setting, but now my space here that you guys are seeing where the virtual learner is showing if they're joining us from home, this becomes the office. So when I have them joining from home, I usually tell them, make sure that you're in a place that looks professional, having the microwave, the bed, a religious image, is not good in the context of seeing a patient. Make sure that you have good lighting, make sure that you have good equipment, that you have good earphones, and that you can actually be in a place where we can avoid any of the distractions. And I usually tell them, if you're at home, just maximize your platform capacity, use the backdrops, use anything that you can to make it more professional. So I'm going to really be focusing on an encounter just, go into the physical exam. And there are three important things for the residents to know that we have to pass on to them, that as they start, they should introduce themselves. They should let the patient know what their role is and what is the objective of that encounter or of that physical exam. For example, at the bariatric clinic, when I do my pre-ops, I tell the patients, I'm Dr. Tivoni, we're gonna go over your medical history, we're gonna talk about the surgeries, and we'll give you time at the end to go over some questions. Very important to ask our learners to confirm the patient's identity. My experience is that a lot of people log in through different devices that they are not theirs, so always important to confirm if the patient that you are seeing is, if the device that is showing a name is the patient that you are supposed to see. Never assume that the patient that you are seeing is the one that actually has it's the name that you see in the camera. And I think it's very important that before we do any type of physical examination of encounter, that we ask the patients if they consent for this, the use of virtual medicine. We are very aware now of the Zoom bombing. We're very aware now of, the conflicts and the confidentiality issues. So it's important to ask the permission of the patient, especially if you're going to be asking them to show you a part of their body, whatever is the belly or whatever is the shoulder, so it's important to ask for permission. So for any type of system organ examination, I think I usually tell the learners this, and the minute that the camera is on, that's the moment that you actually start your virtual physical exam. As I'm introducing myself, as I'm telling the patient what is the plan for this encounter, I'm looking at the patient, I'm having a sense of the general appearance, if the patient is well looking, if it's ill looking, if they look pale, if they look, they have a yellow tinge of the skin, if they're looking diaphoretic, if they are having trouble talking, if they're looking disheveled, if they are not, in a good environment, what their nourishment is. So as we start, as the camera, the Zoom camera camera is on, that's when the physical exam, the observations actually starts. And I'm not shy at all asking the patients to position themselves better. I have to ask many times the patients, listen, can you go back a little bit so I can see the upper part of your chest? You don't want the patient showing you only their face. So be very comfortable asking the patients to find a position where you can do, your physical exam. And when we go into the abdominal, the neurological exam, I'll talk more about, a bit of positioning. And I think that the big difference with these virtual physical exams is that we are engaging the patient as a partner. When we have them in the office, we get them in, we sit them in the chair as we are typing maybe things in the electronic system, and we go to listen to the patient. But this is very different because you really want the patient to be your partner, and you have to engage them more. For example, when you're going to be doing the abdominal exam, can you be in my hands? Can you palpate? Can you take your temperature? Can you do this for me? Can you show me? Can you bring your chin up? There's a lot of things that we can actually ask the patient so that the physical exam, it's better for us. So most definitely one of the difference with the regular physical exam is that the patients definitely need to be more engaged. So always the question is, how do we do a proper cardiopulmonary exam virtual? And I'm really going to focus today on having the patient on camera, because it's very difficult to do a physical exam on the phone, although you could still definitely get very good clues, right? And again, if, for example, I'm going to see a patient in the office because they have a respiratory condition, or there's a concern about heart failure or a cardiac problem, always when we start by looking at the general appearance of the patient, are they well looking? Are they breathing normally? What is the speech quality? Can they speak in full sentences? And this is when, we always are very keen on getting our vital signs. And I usually say, listen, these days it's very easy to teach a patient. They might have devices. It's easy to coach them on how can they get their heart rate, how to palpate their pulse. It's very easy to tell the patients, come closer to the camera. I'm going to be staring at your chest for a few minutes. I'm checking your respiratory rate. Hold on for me. And if they have a thermometer or a blood pressure cuff, we can actually ask them to get those measurements for us. There are a lot of patients these days, we shouldn't underestimate them, that actually have pulse oximetries at home. Important questions for the patients is, for example, if you're focusing on a cardiac problem, have they noticed increased shortness of breath? Have they decreased exercise tolerance? Are they, when they're talking to us, do they have any cough? Can they tell us if they have had more trouble with orthopnea? The weight has changed. Have they noticed any leg swelling? And for me, over the times when I'm actually doing my physical exams in the office, many times I ask the patients, are you on an iPad? Are you on a phone? Can you bring the phone down to your legs? Or if they cannot do that because they're on a desk computer, I ask them, listen, if you push over your shin, would you make an indentation? Are your legs showing any signs of swelling? Do you have any brown patches in the skin? Do you see any discoloration? Do you have any? So there are a lot of questions that even without a camera can give you a good idea of where the patient is in terms of cardiovascular health. In regards of pulmonary conditions, asthma, frequent visits to the emergency departments or the family doctor's office, chest infections, especially now going into the fall. As the patient is talking, do you notice we can instruct our junior learners to specifically look for prolonged expiration. You can ask the patient to take a breath in and a breath out, see if they have any overt wheezing. Are they coughing as they're doing that? When they are talking, are they speaking in full sentences or broken sentences? Are they using any of their accessory muscles? And we all have to understand that any virtual physical exam, and in particularly the cardiopulmonary exam, has limitations. You won't be able to do an auscultation. You cannot do a palpation. You will only get a blood pressure reading if the patient has a device, to record the blood pressure. And the same with their weight. They must have a scale at home. And, of course, the temperature, they might actually have a thermometer. I'm going to ask all of us to be advocates of virtual medicine and telehealth. And I'm going to show you in this picture a 90-year-old gentleman, this gentleman that you see here, that through OTN, he is actually, and through a remote patient monitoring, he is followed very closely by a team in regards of his heart failure. And he has a scale at home, he has a blood pressure cuff, he has an oximeter, he has a thermometer. So we shouldn't underestimate the instruments that patients have at home, that they can make our assessment better. And we should encourage patients. We're going into the era of telemedicine, so we should encourage our patients to have, if they need it, devices that they can give doctors when they see help the physicians do their assessments. We all know about the watches, the smart watches for sports. I saw a patient at the pre-op clinic the other day, and he has an Apple Watch, and he has atrial fibrillation paroxysmal, and he knows because his Apple Watch tells him when his heart rate is irregular. So definitely the patients can do much more than what we think. In regards of the abdominal exam, and unfortunately we don't have a solid science behind any of that would validate any of the things that we do virtually in terms of physical exam, but most people agree that the abdominal examination is actually the most challenging to do. And we usually need, or ideally would like to have, a third person in the room, a partner, a family member, a friend. You have to very specifically ask the patient to position themselves, to lie down, make sure that they expose their belly. And again, it comes into mind asking for consent prior to them showing any parts of the body to a camera. And you have to actually ask the patient to be very active on localizing first for you where the pain or the discomfort could actually be. We shouldn't be shy asking the patients to use their phone, their tablet, to show us properly and so that we could see if there are any scars, if there are any hernias, if we can even see with the camera if there are any masses, and we can always ask the person that is in the room if they see any of those things. If the camera, for example, the image is actually not very good. Over time, I find little tricks. For example, asking the patient when they're laying down, suck your belly in, blow your belly out, or you ask the person that is just beside them, can you just shake, the couch really well or the bed very well? And this is really, for example, to elicit peritoneal sounds. And it's important when we are doing an abdominal virtual examination to coach the patients through what do they need to do. And this requires education. So we all have a different method. We all, have a system for any physical exam that we do. Make sure that you guide the patient or the bystander through how to do the light palpation and the deep palpation of the abdomen, and teach them a technique. And it would take a lot of time to go over, the abdominal exam. I hope to have, some videos coming out soon, but it's important to coach the patient very well so that they can tell us where the pain is. We should educate them about the quadrants in the abdomen that we worry about. We can ask them to do different maneuvers. Put your fingers under your rib, take a deep breath. Does that make the pain worse? So we really have to be more practical in the sense of really coaching the patient to do the things that we want them to do for us. And in terms of what are the limitations on an abdominal exam, well, we won't be able to do an auscultation. The palpation is by a third person or the patient. And what I find that it's probably the most, difficult is that when we're so used to, when we do an abdominal exam, to feel the belly, look at the patient's face to see if when we push down, when we let go, do we see a facial expression of pain? And unfortunately, with the virtual physical exam, it is definitely a big challenging, because you can either ask the person that is there doing for you, but once you express what we are looking for, you might actually have, not the result that, it's what it is. Yeah, so most definitely the abdominal examination is the most challenging. The neurological exam, and there are actually videos, to do a proper neurological exam. I find that, really I don't want to say that it's actually easy to do, but if, again, we all have a system, we all do a neurological exam covering, the multiple different steps, and mental status, it's easy to do when you have the patient on camera. If there's a person beside them, asking them the usual questions, orientation, memory recall, language, speech, so that you could definitely do very well on camera. There are definitely limitations with a cranial nerve examination. You can do almost everything except your number 1, 2, and 3. The pupillary reactions can actually be challenging, but there are a lot of, help for these things. These days the cameras are actually pretty good. If you ask the patient to come right onto the camera, if you ask them to actually shine, a light, or a third person shining a light on their pupils, you will be surprised on how much you can get. You won't get anything in terms of olfactory, but definitely you can get much more than you would actually imagine. Unfortunately, for motor power, when we're actually the neurological exam, has to be assisted by a third person, and it's one of those parts of the neurological exam that probably doesn't have the highest yield. The same for muscle tone and muscle bulk. Really, you have to completely rely on the individual that is in the room. And gait and stance are actually very easy if you have a good camera. You just have to ask the patient to stand up and to walk, and you can see them as they are doing that. Cerebellar testing, it's also simple to do, and definitely it's actually of high yield. And when it comes to sensation, you really have to be very creative, because it's one of the parts of the physical exam that actually can be more challenging. I invite you all to read the paper that is actually at the bottom of the slide, the virtual physical exam in the 21st century, and it tells you a little bit about how to go system by system, how to go organ by organ. We're not going to go into examination of the thyroid, or very specific MSK examination, back pain, which is so common. But these days, more and more physicians are trying to come together and trying to share their experience and what has worked for them in terms of little tricks and maneuvers that can actually help to nail a good physical exam. The cameras are ideal, and dermatology is ideal for telehealth. Just think, that with the very good cameras that we have today, type of lesions, their location, their extension, any type of wounds, the depth, the length, if there's any erythema, discharge, eczemas, if a lesion is palpable or not, you should engage the patient and ask them to press down, push down, and they can show you. And you really need to be very active and engage the patient on asking them, make sure that I need to see the rash, I need you under a good light, I need you to do this for me. And of course, these days, I have patients sending me through email or uploading in our patient portal their pictures, and has such a tremendous role, the dermatology, virtual dermatology, that of course the OTN has a great portal and a great initiative in terms of dermatologic access to dermatologic care in the province. I always tell the learners, after you've done everything, after you have done in your encounter, your history and your physical exam, make sure that you summarize the encounter to the patient, explain the limitations of what you have done. And when I do my pre-ops at the bariatric clinic, I'll tell the patients, we have gone over a virtual physical exam. It has tremendous limitations. I couldn't listen to your lungs. I couldn't take your blood pressure. I couldn't get an oximetry reading. But prior to you coming to the hospital, you're going to be seeing anesthesiologists, and they're going to be doing the part that I cannot do today. And believe it or not, preoperative assessments in the virtual world are happening. And I think that California probably is ahead of the game. And it's important for our residents, for our learners to know that they have to be very clear instructions, when they're doing virtual care. They have to let the patient know exactly what that learning is doing, I'm going to talk to my attending. This is what I'm going to be doing. If everything is okay, we're going to be sending, if my plan, it's working, we're going to be contacting your pharmacy. And important to make sure that the patient also understands very clearly what they need to do. And in the virtual world, the follow-up is as important as in the in-person assessment. So it's important that the patients have, a very good understanding on what is going to be the follow-up. Whether it's going to be just a phone call, whatever it's going to be just a quick email, everything is fine, took the antibiotics, even though everything worked great. It's important to have a very good, closure on the follow-up. And I always tell the residents the same. If in any doubt, we have to bring the patient in. And there are many times where I've been doing a pre-op assessment, for example, online with a resident or a junior learner, and just, you're just not happy. The patient is sitting, you cannot see much, they're not going forward, so you can see their chest, In my case, the BMI is way too large. And if you have any questions in any situation, you just have to acknowledge that this is, a modality that has not been validated, and that when in doubt is much better to bring the patient in to be safe than actually to be sorry. And I put at the bottom some very good resources from Stanford University. There's a lot of videos, online of physicians sharing their experience on how to do, a thyroid exam, a full neurological exam, and an abdominal examination. But if anything, I'm a strong believer that virtual medicine, virtual care is here to stay. In the States, they've been doing it for over 25 years. For us, it was really COVID that was a catalytic, reaction for us to go into the virtual world. But in terms of telehealth and telemedicine, I really think that these days the sky is the limit. There's much more that we can do in a very safe way to offer care to our patients in a more really in a more a patient care way, in the sense that we are bringing medicine to them in a time that is convenient to them in their own environment. So if anything, I'm a super fan. Still, we're going to be seeing, hopefully in the future, more people doing virtual exams and sharing with the rest of us what had they found that it really worked on their assessments. And I think that with that, I'm gonna finish my talk, and of course I will take any questions in regards of sharing my experience at the clinic, or anything that you guys might have in terms of specific virtual exams.
Thank you so much, Maria. That was absolutely fascinating addition and a great segue from Heather and Becky's talk, and also from Keena's layout of sort of the lay of the land and where we were at before the pandemic. It also makes me realize that, I think you and many others realize that this was the answer to geographically isolated patients who maybe could get into a clinic with a nurse practitioner but couldn't get to a specialist. And I'm sure now that when you have the opportunity to see a patient virtually and there's actually a trained healthcare provider there who can help with the physical exam and demonstrate that to you remotely, it must feel like a huge gift compared to just walking a patient through it on their own or with their partner at home.
Absolutely, absolutely, Jill, you're absolutely right. And I mean, it would be interesting for all of us to see how our colleagues, unfortunately for themselves, have taken this, to the, limit, in the sense that, these days in the States, because of the lack of intensivists, for example, they have remote ICUs with an intensivist in a huge room, with multiple monitors, where the ICU, the remote ICU rooms have, this incredible equipment. So really, when it comes to telemedicine, I really think that the sky is the limit, and we just have to get more comfortable, because there are a lot of things that, we can definitely do that we think that they might be challenging or difficult.
And I think amazing. One of the things I was going to raise, actually, Maria, is that I like how you have explained that so much of this is new for everyone. So when you're orienting your junior learners and they're asking you questions and they're expecting you to have some user's guide in the back of your, like armamentarium, I think this is where you get to carve out to say, we might not have one of those maybe at some point. we can have a rational clinical exam series paper on this stuff, but right now we don't have actually a lot of data on what works and what doesn't. There's some emerging data, like you pointed out, but there's not a lot of hard and fast rules. So I think it'll be interesting as this virtual physical exam field changes. But I think it's going to be just the reality that our learners will be learning alongside us.
No, absolutely, absolutely.
Great, and we'll move on to Dr. David Fahmy.
Thanks, Jill. So what I want to talk with you guys about today was to kind of dig into some of the logistics of finding a way to be teaching the learners, especially when it comes to content knowledge. So coming from an allergy immunology, a lot of what our learners are seeing, even the bread and butter stuff, is a bit novel. And so when COVID started, we basically had no junior learners. They're all kind of taken off the service. And as they've transitioned back, we've kind of been faced with these new challenges of making sure that they're completing their assessments, like what was talked about earlier, but then also finding time that they're able to get as much out of their limited time with us in allergy immunology as possible. And so I will I'll share my screen. So yeah, what I wanted to do is just build on others' talks and present some data actually from our own program about whether we actually really needed to adjust, and then get into some tips and tricks that I think we as a division have found helpful, and then hopefully others will find helpful as well. And so I want to start with basically the way that our clinics run to this point, which I think is probably the way that many outpatient clinics run, where learners gather at some communal setting to begin. They run the list of patients for the day, and maybe patients are assigned. They go on and have their patient encounter. After the encounter is done, they come back and they discuss with the staff. They agree on a plan. They go back in, they discuss with the patient. Then after that, they wrap up and they teach, and there's feedback. And obviously with the transition to CBME, there's more direct observation. So this is transitioning a bit, but that's generally kind of how we've been able to do it prior to COVID. And so with COVID coming, we started to wonder whether we actually did need to make any adjustments as we transition to the virtual clinic. So one of the fellows and I created a questionnaire that we sent out to our trainees and our faculty just to get an idea of how we were doing about 3 months into this transition. And so the first thing we asked them was, are your learning objectives being met? And really, most people basically said, no, not all of our objectives are being met. And I think one person said not at all. So that was a bit of a red flag for us. And then in terms of their assessments, we talked about how direct observation could potentially be even more easily facilitated through virtual care. And so we asked about that. Has this happened more as we've kind of transitioned to CBME and now with this extra technology? And the answer was, well, not really. It's either kind of stayed the same or gone down. And then feedback overall, how has that gone? And both of our faculty and our residents all said that there was probably less formative assessments happening from clinic to clinic. And so then when we asked, well, where do we need to improve to make the transition more smooth? The first thing that popped out was clinic organization and execution. And the next thing was that there needed to be more teaching around these cases. And when we kind of dug into some of the narrative responses that they gave us, the feedback, that the themes of the feedback we were getting was that the clinics felt too busy. There were a lot of logistical issues in getting this started, and that's creating a bit of an obstacle. And because of that, there was really no time or space for teaching. And so when we think about teaching, or when I thought about teaching, the teachers who stood out to me in my training is what I would call the best bedside teachers. And by that, I mean those who are able to kind of in the moment provide organic teaching that comes out of the flow of the clinic or out of the patient encounter, which is something that many of us had become accustomed to as both learners and supervisors. But in the virtual environment, it seems like that was starting to become compromised. And so I was recently introduced to the term website teaching, which I think actually Becky is the one who introduced me to that. I think we've come across the term website manner a few times. We're kind of stretching that into website teaching was really insightful. And I think that really kind of helps operationalize what seems to have started to, that we started to miss in our day-to-day clinics. The question I started to ask when it became clear that we're going to be doing these virtual clinics for a while was, how do we simulate the in-person experience as best we can to make sure our learners are getting as much out of these rotations as possible? And what became clear is that it wasn't going to happen without some active effort to create the time and the space for the teaching to occur. So I started to make some changes to the way I ran my clinics based on what some other people were doing, based on talking with people in the medical education world. And I've come up with some suggestions that have worked really well for me that I want to share with you today. Really what the biggest things was creating time and space to allow for this to happen. And so let's actually start with ways to create more space, because I think it's actually a bit more straightforward. As I alluded to before, in my in-person clinics, most of the teaching and learning happens in this communal space that we call the team room or the muster room. And so early on, I realized that we needed a spot where we can get together to learn virtually. And that led to the creation of this virtual team room, right? And practically speaking, what that is it's a Zoom meeting that starts at the beginning of the clinic where all the learners are. And it gives us an opportunity, a communal space to discuss patients. And then it's a chance to teach around cases as the clinic progresses. From a time perspective, it goes back to actually a lot of the things that we learned about in some of the CBME workshops that we had earlier in the year before COVID happened. And the biggest thing is a term that you've heard today is intentionality. And this was brought up many times as key, and the lessons and strategies learned from the CBME transition I've actually found to be quite helpful in this transition to virtual care. And I'll give you some examples. So the first thing is prepare a little extra. Take that extra step to think about what patients are coming in, their complexity, and matching that with the learners coming in and their level of training, and also thinking about interesting things that they could potentially learn from that encounter. So that way, when you see the patient, you can make sure that you're highlighting those key points. Another helpful strategy has been to prepare your learners. And I've seen this happen in two forms. One is to gather your virtual muster room and run the list with everyone and highlight to them what you would like them to see. And another is to send an email the night before or the morning of, and that can allow you to kind of explain how you're expecting the clinic to be run. Because again, the experience is going to be different from clinic to clinic as they're rotating through. And it also, if there's an interesting case coming in, you can kind of highlight that to them so that they can prepare prior to the clinic. And so personally, I tend to do both, where I'll send the learners in my clinic an email that orients them to how the clinic is run, and about the virtual team room and about the types of patients they might be seeing that day. And then I'll let them know if there's a rare disease coming in so they can kind of read about it beforehand. And then the morning of, we gather and we quickly run through the list before we divvy things up. And then the second tip I got was a tip from Teresa, again in the context of CBME, but I think it works really well in the virtual environment. And that's to make your learners the last patient of the day. Reserve that last 15-minute slot of the day for your learner. And so depending on how the clinic has gone, it could be used as a time to answer questions, to provide feedback, or to teach around an interesting case that they may not have seen that day. And then there are a few tips that I got from others. There's actually a virtual teaching conference out at UBC, I think in August. And a couple of things that really stuck out to me that I've started to incorporate in my own clinics, especially when it comes to things like physical exam, which Dr. Taboni was just talking about, but also their assessments. A lot of things are being deferred or modified as a result of COVID. So making sure that the learners are thinking through what they would do in person, as well as how they would navigate it in the current climate is important, because there is a chance that a gap in their knowledge or their skills starts to occur because they're only experiencing this in a virtual environment. So making sure that they've thought through that can be helpful to fill that gap for when they actually get out there with future experiences. The second thing I thought was really important was with this focus on trying to increase the fidelity of the situation. I'm going to make this as close as possible to a regular clinic. At the end of the day, no matter how hard I try to do that, it's still my learners sitting there potentially for 4 hours in front of a screen. And so the term I heard from one of the speakers at UBC was mix in some green time with your screen time. And so telling them to take 5 minutes between patients to go and stretch, to go outside and see the sun, have a drink or a snack, won't significantly slow down your clinic, because if they're taking about an hour to see a patient, an hour and 5 minutes probably won't make too big of a difference, but will go a long way in helping them feel well, and also potentially helping them stay more engaged when you're doing things like teaching later on in your clinic. As you can see, we've kind of gone from the good old days, and then hopefully with some of the tips I've talked about today, we can move into the good new days, right? Where learners can receive an email the night before with what to expect. They can join a virtual team room where patients are assigned. The learner can then contact the patient for the encounter. They can return to review with you virtually, and then you can go in together virtually with the patient, whether that's through OTN or phone. That gives you an opportunity to teach around the case if in the moment, if you're able to, and then you can assign the next patient, tell the learner to take a 5-minute break, and then congregate at the end of the clinic to highlight an interesting case to teach around. So I'd love to get everyone else's thoughts on their experience, and I'm happy to answer any questions at the end. Thanks.